Understanding Medicine.
I'm Professor Aziz-ur-Rehman, and after the videos on acute viral hepatitis and chronic hepatitis C, I'm going to talk about chronic hepatitis B, which is again an important condition, perhaps not as big an issue as it was chronic hepatitis C because that was commoner, and hepatitis B, because of the vaccination available, is becoming less common, but still fairly prevalent in our country, so we need to know about it. Definition: what is chronic hepatitis B? If somebody have acute viral hepatitis B, normally surface antigen disappears within 12 weeks maximum. And of course, DNA also become undetectable because there is complete resolution. Only antibodies against surface antigen and E antigen, they persist. But if somebody continue to have positive surface antigen 6 months beyond acute viral hepatitis B, that person is formally labeled as a case of chronic hepatitis B. And second possibility is somebody did not have any symptoms, just going through some routine investigation, and they were first time found to have hepatitis surface antigen positive with no history of jaundice at all. Now this, surface antigen does not become positive as a result of vaccination. So positive surface antigen means that this patient got acute or subclinical infection in the past, but the virus did not clear and it persisted. So both these conditions would qualify for the label of chronic hepatitis B. This is the virus. It's a DNA virus like all other hepatitis viruses. Hepatitis B virus is a DNA virus. Does that matter? Yes, it does, because this virus has some special characteristics. It can convert into CCC DNA, and this CCC DNA can hide in the hepatocytes in a place which is not amenable to medications, current medication. So that is why we say that we can only control replication of chronic hepatitis B. We cannot cure it with the available medication at the moment. Of course, there are many in the development and they might be able to cure, but at the moment we can at best control this virus. And this is the particle, and you can see the surface antigen, you can see this DNA, you can see the E antigen, you can see the core antigen. All these are important components of this virus which are relevant to our discussion. Transmission is same as hepatitis C. I would be missing some details because the same concepts have been discussed in chronic hepatitis C. So basically it is parenteral, because if you ingest the virus, it is destroyed in the stomach. So I think there is no fecal-oral transmission. It is mostly parenteral, either in the form of intravenous drug use, unsterilized medical or cosmetic equipment, transfusion of unscreened blood, which should not happen these days because all the donated blood is screened, then sexual transmission. It can also transfer from mother to child, usually at the time of delivery. Whether a lactating mother can transfer the virus to the baby through milk is doubtful, most probably not. So I think this is the mode of transmission. Clinical presentation, first of all, we all need to know it could be an incidental diagnosis. That means somebody went for blood donation, or somebody was screened for immigration purposes or for employment purposes, or patient had some other illness and during routine investigation a positive surface antigen was found. Then it could present with non-specific symptoms of chronic illness like low-grade fever, Mostly it is actually feverish feeling rather than fever. Chronic fatigue, which of course have other causes, and myalgias. So I think in somebody, whether or not there is history of jaundice, if somebody presents with these symptoms, we definitely need to rule out many conditions, including chronic hepatitis B. Then sometime it can present with extrahepatic manifestation. For example, it could cause a condition very similar to polyarteritis nodosa. So I think that is another manifestation, or sometime skin manifestation. Chronic liver disease, very unfortunate outcome. We still have people who are first time diagnosed when they have already developed chronic liver disease. So they might come with one of the symptoms of chronic liver disease, and on investigation find that this patient had chronic hepatitis B, which has caused chronic liver disease. And similarly, hepatocellular carcinoma, somebody presenting with liver mass, and on investigation we find out that this guy had chronic hepatitis B infection. Now about the laboratory investigation, there are two types of investigation which we need to do in patients with chronic hepatitis B: the biochemical test and the immunological test and the imaging test. In biochemical and immunological test, we of course first do liver function test. It is best to have complete panel of liver function test, but just ALT may be sufficient because the decision is mostly made on ALT, whether or not this patient needs to be treated. I think ALT may be sufficient, but perhaps it is better to have complete liver function test to know about the proteins and other things. Then surface antigen of course needs to be done. This is probably done before patient comes to this stage. Patient has been identified a case of chronic hepatitis B on the basis of positive surface antigen. Then E antigen should also be done because it would help you to classify chronic hepatitis in two broad categories based on E antigen, whether E antigen is positive or negative. That has some bearing on the treatment. Hepatitis B virus DNA PCR quantitative. So DNA must be done before we undertake treatment, and it should be quantitative because various societies have given a certain number, a certain cut point above which you need to treat, and this would also depend on the fact whether somebody is E antigen positive or negative. The cut point given by American Association for Study of Liver Diseases is different based on E antigen, but European societies, they give the same cut point whether or not E antigen is positive. But DNA must be done because that is the only, I think, definite evidence of replicating hepatitis B. Only the replicating hepatitis B, which is causing inflammation, is treated. Then anti-HDV, you all know hepatitis D could be a superimposed complication of chronic hepatitis B. So we want to know if somebody has hepatitis D infection also or not. Then alpha fetoprotein, this is a marker of tumor, and sometimes patient with chronic hepatitis B can silently develop a hepatocellular carcinoma. So of course we want to rule out that possibility before we start treating these patients. Anti-HCV and anti-HIV are also done because we need to actually know the entire patient. So if somebody has these concomitant infections, they also need to be treated. Now in imaging, ultrasonography is the greatest. This is very simple, readily available, and can be done on the bedside, and this is very, very useful. The primary objective of ultrasonography is to see if somebody has already gone into chronic liver disease stage. Somebody has already developed cirrhosis. Cirrhosis will be covered in separate videos, but ultrasound is very useful to detect cirrhosis. Of course, very mild cirrhosis may not be detected on ultrasound. But if somebody has changes on ultrasound, that means some significant damage of chronic hepatitis B has already occurred. Then fibroscan is a new type of scan, and this can actually determine the presence of fibrosis, and this is becoming a substitute of biopsy. So this is also a useful test. Then others as needed, CT scan may be needed. Biphasic CT scan will be particularly needed if we suspect hepatocellular carcinoma. And then MRI, another test may also be needed, but I think I'm going to skip the details here. So these are the investigation before we start treating, or in fact before we make this decision whether or not this patient need treatment. We need to have these tests. Particularly, I think E antigen, surface antigen, and ALT, and these are the DNA. So these are very, very important before we undertake treatment. Now, this is a little complex slide, but I'm going to describe it briefly. It is natural history and various phases of chronic hepatitis B. Chronic hepatitis B passes through various phases, and ultimately the lucky people would get cured, but most would continue to have some kind of chronic hepatitis. Now, this is the old terminology which is now not used, and it was very, very confusing. Even the newer concepts, though relatively easy to comprehend, is slightly difficult for many students. I'm going to try to explain. First of all, just notice there are 5 phases: phase 1, 2, 3, 4, 5, and all individuals, they do not necessarily pass through all these phases. And number 2, your patient could be at any phase, any stage when patient comes under consideration. So first 2 are E antigen positive. In the initial part, E antigen is usually positive. So phase 1, phase 2, E antigen is positive, and phase 3 and phase 4, E antigen is negative. And in the final phase, when patient is supposedly cured, there is no evidence of, there is no E antigen, and there is also no surface antigen here. Very, very few people reach this stage, but if somebody does reach this stage spontaneously or with medication, that person would not have surface antigen positive, and DNA will also be negative. Now then, please also see these 2 words, chronic infection and chronic hepatitis. If somebody carries a virus but does not have inflammation, he is a case of chronic infection. But if there is evidence of liver damage in the form of increased ALT, or in any other form like evidence of liver damage on ultrasonography, that patient is described as a case of chronic hepatitis. So chronic CHB infection or CHB hepatitis. Okay, this person has positive anti-HBC, surface antigen is positive, E antigen is positive, and DNA is present and usually in a very high titer. And this patient may have normal ALT. Now this is important. I think I would like to draw your attention here. ALT is normal, signifying that there is no damage to the liver. So virus is there, it is replicating, DNA is there, surface antigen is there, E antigen is there, but there is no immune response to the virus, and there is no damage. That is why they were called immune tolerant. So this is CHB infection. Okay. Now this is stage 2. Again, they are E antigen positive. The rest of the things are same. DNA is there, it is fluctuating, but ALT is elevated. All right. So this is the point which differentiates between the 2. ALT elevated unless there is a clear-cut alternate cause of elevation of ALT. In this context, elevated ALT would mean that there is immune reaction to the virus resulting in liver damage. Elevated ALT could indicate progressive damage, and there may be fibrosis, and body is actually the immune mechanisms trying to clear the virus, but as a result there is liver damage, and it is an immune response to the virus which is actually more damaging. So we have to control this stage. This patient would probably need treatment because there is active viral replication. In phase 3, patient becomes E antigen negative, but again, like phase 1, ALT is normal. And this patient has DNA at the low level and it is inactive and residual. This patient may not have any symptoms, and this patient could develop cirrhosis, actually may have already developed cirrhosis, but at this stage there is no immune reaction, and this is again called CHB infection. And then the stage 4, again there is a reactivation. This is called reactivation. It could come anytime, maybe 10 years, maybe 20 years after the acute infection, or whenever the immunity is down. Then again ALT becomes active, immunity becomes active, and ALT is elevated. This is CHB in hepatitis, E antigen positive, E antigen negative, sorry, E antigen negative CHB hepatitis. That this is the our current treatment cannot achieve this, but if spontaneously somebody with treated interferon would develop, look at this one, no surface antigen here and no detectable DNA, ALT normal, and this patient has got no evidence of infection, but antibodies against E antigen and antibodies against surface antigen and antibodies against core antigen may be present, would be present, and this is to differentiate it from a person who never got exposed to hepatitis B virus or the person who was vaccinated. All right, so these are the markers of chronic infection even if person is completely recovered. I hope this made some sense to you. If you are unable to understand, you can pause this video here or replay this part. But I have made a summary in the next slide, summary of this concept in the next slide. So basically what we are trying to do is that we are going to see if somebody has CHB infection or CHB hepatitis. Both have virus. Both are likely to transfer virus to others or may transfer the virus to others, right? But this one is just virus, no immune response and no liver damage, and this patient might not need treatment, at least at this stage. And this patient has got active hepatitis, so hepatitis can progress to chronic liver disease. This patient would need treatment. But you never know when CHB infection becomes CHB hepatitis. So there's a tricky situation. In this, you will probably not give any antiviral, but you will have to keep an eye because when patient's status changes, the treatment also changes. So surface antigen is positive. E antigen may be positive or negative. I just told you in the last slide. And DNA would be positive, usually in high titer. This high titer should not make you feel nervous that this high titer will necessarily cause more damage. It is the immune response which damages the liver. Then ALT is normal, and normal criteria is different in the context of chronic hepatitis B. In men, it should be less than 29, and in women, it should be less than 19. Only then it would be called normal. Now, values above this may still be within the usual normal range, but they are high in this context. So, liver structure would be normal on ultrasonography, fibroscan, CT, and MRI. In chronic hepatitis, CHB hepatitis, surface antigen is positive like this one. E antigen may be positive or negative like this one. DNA is positive, usually a lesser titer, but ALT is elevated. ALT in men more than 29 and in women more than 19. That would be considered elevated, and that would imply hepatitis, and that would imply the treatment is needed. then same could be in some patients ALT may be inconclusive, or there may be another reason for having high ALT. In that case, we use liver structure abnormalities. Now, what we are actually interested to know is if there is any liver damage. This ALT can tell us, and these investigation imaging tests can also tell us. So if ultrasonography shows evidence of early chronic liver disease, even if ALT is normal, I would take it as an evidence of liver damage and I would give treatment to these patients. So I hope this was simpler than the previous slide. So after differentiating with E antigen, we want to know if there is liver inflammation or liver damage based on ALT and ultrasonography. Those who have evidence here, they need treatment. Those who do not have evidence of liver inflammation and liver damage, they just need surveillance. They need to be monitored. In case they go into this phase, they would require treatment. This is why we are concerned about these types. Chronic hepatitis B infection can, of course, they have virus, in fact, in high titer, and they can transfer infection to others, and the other person could develop acute hepatitis and can flare up, and very low risk of hepatocellular carcinoma. This is very reassuring because there is no actual immune damage. So the chances of hepatocellular carcinoma in these patients would be very low, extremely low risk of chronic liver disease, and antiviral treatment is not indicated because we have not, there is no evidence that in these patients antiviral treatment would do any benefit. But in case they go into the other phase, then of course the treatment would be indicated. In chronic hepatitis B hepatitis, they can also transfer infection. They can also have flare up in they have chronic hepatitis, but there could be flare up in hepatitis. They have a relatively high risk of hepatocellular carcinoma and relatively high risk of chronic liver disease, and treatment is needed for life. Now, there was a time when we used to treat these patients, and annually we do if they have seroconverted. And then waiting after 6 months, after the patient has achieved the seroconversion, biochemical conversion, molecular conversion, then we would wait for about a year and then we would terminate the treatment. But many such patients, they would have a relapse of infection. So as of today, whatever treatment of chronic hepatitis we give, it is for life. We do monitor these patients and we do feel very good if patient achieves seroconversion, but we do not stop medication because theoretically there is a possibility, but during the life there is, whenever somebody gets immunosuppressive therapy or there is immunity is down, this virus can get activated again. So life treatment is lifelong. So I think you would now appreciate why it is so important to differentiate between CHB infection where no treatment is indicated at all, just reassurance and some annual surveillance, and a condition where lifelong treatment is needed. Luckily, the current treatment is very easy to take and very safe to take, but of course it is expensive and it is psychologically not easy to accept that you need treatment for life. So I think we need to differentiate between the two conditions. Treatment of chronic hepatitis B and expected response. In chronic hepatitis B infection, AVT is not indicated, and just annual surveillance for hepatocellular carcinoma and alpha-fetoprotein and ultrasonography and ALT. In chronic hepatitis B infection, the treatment is lifelong, and the expected response, we expect that ALT be normalized, and we expect that E antigen, if it was positive previously when the treatment was started, if the E antigen was positive, it becomes negative, and antibodies against E antigen become positive. This would be a good response, and then we also expect that DNA becomes undetectable. We don't say it becomes negative. We use the word undetectable because although the neuroassays are very sensitive, they can detect very low levels also, but on the test it becomes undetectable. We understand that some virus still persists in the body, if not in the form of DNA, in the form of CCC DNA, hidden somewhere, usually in the hepatocyte. So true response, when would you say that patient has got achieved true? This is actually biochemical conversion, this is serological conversion, this is molecular conversion. But the true response, which is not achievable with current medication, is somebody whose surface antigen becomes negative. Antibodies against core antigen would continue to persist, indicating that this patient had infection in the past, but surface antigen becomes disappear, and the chances of becoming surface antigen negative is so low that we don't actually monitor. We only hope that patient becomes negative, but those who are very lucky, they become negative. Prevention, avoidance of risk factors, then post-exposure prophylaxis. If somebody got a prick, imagine some surgeon, some phlebotomist, somebody got a needle prick injury after taking sample from somebody who was positive or some other kind of exposure, then hepatitis B immunoglobulin can be given. One kind of exposure is a baby who's born to a mother who's surface antigen positive. So hepatitis B immunoglobulin can be given. This will give you a short and immediate protection, and this should always be followed by active vaccination. And universal hepatitis B vaccination is current standard. All newborns should be vaccinated. Antiviral treatment, and what treatment we give, it could be interferon based treatment, and this treatment of course theoretically has some advantages, but it has got so many issues and so toxic, so difficult to tolerate, so expensive that nobody actually takes it. In the literature, it is mentioned that first we should try pegylated interferon 10 million units, international units, subcutaneous once a week for 48 weeks. But I will not go into the detail, but this is very toxic treatment. The advantage is that if somebody seroconverts in response to a pegylated interferon treatment, then his or her chances of permanent cure is much more than the treatment with nucleoside analog. So, but this is definitely more practical, and because this is very easy. So we have two options. One is entecavir, which is 0.5 milligram, usually one tablet a day. But sometimes we have to give 1 milligram, which is 2 tablets a day. Just once a day, whatever time, with or without meal, usually for life. And alternative is tenofovir, disoproxil fumarate, 300 milligram once a day, or one improved form of tenofovir, that is tenofovir alafenamide, and this has got more penetration, and you can have the same effect of 300 milligram with small dose 25 milligram, and this is less, the side effects are less. So these days we give either entecavir alone 0.5 milligram or 1 milligram, or we give tenofovir alafenamide 25 milligram alone. In some cases, in resistant cases, both can be given as a combination also. And this treatment is for indefinite period of time. Usually for life, though many patients tend to stop it and then we have to reconsider if we have to restart the treatment or not. But in theory, this treatment is for life unless some major change in the patient's history develops and that limits his life, then we may discontinue, but usually it is for life. Why for life? Because this treatment cannot eradicate virus. It can only suppress this virus, and we fear that once we stop it and whenever patient develops some some immune problem and there could be reactivation. Then many are in that development. Now I have not shown you that life cycle to make it simple. The hepatitis B has got a very complex life cycle and there are many stages where we can intervene and make the virus incapable of proliferating. But all these new antiviral drugs are in the pipeline and I'm not going to discuss them in any further detail. And these are the drugs which used to be present, lamivudine, adivofir and telbuvudine, and they are not used these days. Why? Because they are very prone to develop resistance. And unlike these two, and one unique feature of entecavir and tenofovir is that they are very resistant to development of viral resistance. Virus continue to remain sensitive during the treatment. So this is the treatment. Treatment is actually simple. Usually when I start this medication, we tell them that you should not expect anything more than placebo. Patient does not have any side effects at all. Very well tolerated. Although some kidney related side effects, other side effects are possible, we do some tests, but generally very good tolerability. Complication and natural history of chronic hepatitis C versus chronic hepatitis B. Most of the things are common, but there are some differences I'm going to highlight. In chronic hepatitis C infection, patient first develop CLD, a progressive disease, and various stages of CLD, early CLD, compensated, decompensated, and only then some would develop hepatocellular carcinoma. But in cases of chronic hepatitis B, even if somebody has CHB infection, that means we do not consider the need of treatment and ALT is normal. Somebody may not have any symptom. That person could develop CLD or that person could develop hepatocellular carcinoma, or patient does not have to develop CLD first and then hepatocellular carcinoma. So it could be in a normal liver, apparently normal healthy liver, chronic hepatitis B infection or hepatitis can cause hepatocellular carcinoma. So I think this is important. So even if liver looks normal, annually we have to do alpha fetoprotein. Managing hepatitis C and B co-infection, because mechanism of transmission is the same, and people who are IV drug users, they tend to have both type of infections, sometimes with HIV also. So I thought it is important to cover this part also. If somebody has hepatitis C with chronic hepatitis, hepatitis C would be treated just like normal case. That is covered in another video. So hepatitis C part will be treated with direct antiviral agents as we normally do. But chronic hepatitis B infection, those people who have surface antigen positive but their ALT is normal, there is no damage to the liver, these patients should be given, otherwise not candidate for treatment for hepatitis B, but because we are treating hepatitis C, during this phase when we are treating hepatitis C with direct antiviral agent, we should give treatment for hepatitis B also, because there is evidence that the treatment of chronic hepatitis C with direct antiviral agent can actually activate a sleeping chronic hepatitis B infection. So during that phase, we need to cover these patients with entecavir or tenofovir. But those patients who have chronic hepatitis B hepatitis, they qualify for the long-term treatment in their own right, so they would need lifelong treatment. Okay, so I hope I have made myself clear. Hepatitis C would need its treatment like normal. Hepatitis B, if it is chronic hepatitis B infection, just 12 weeks treatment, and if it is chronic hepatitis B hepatitis, then lifelong treatment. Now this is another table which I'm going to compare, I think very briefly. This is a very busy slide, but the virus hepatitis C is RNA, hepatitis B is DNA, mode of transmission in both cases parental. Prevalence hepatitis C, I would say very common, and hepatitis B common. Site of replication, and this is important, chronic hepatitis C virus remains within the cytoplasm of the hepatocyte, whereas this hepatitis B virus goes into the nucleus. That is why it is more likely to cause hepatocellular carcinoma, and that is why it has got the capacity of converting into CCC DNA, and that is why that these patient, because this CCC DNA becomes part of genome of hepatocytes, so these patients, they continue to produce surface antigen even if they are not otherwise having hepatitis. Okay, so chronicity after acute infection in hepatitis C, it is almost the rule after acute infection, very high, and in chronic after acute infection in hepatitis B actually depends on if somebody had icteric hepatitis A, then the chances of going into chronicity is less than 5%. But if somebody had subclinical infection, subclinical exposure, then it is very high in both cases. Post-exposure prophylaxis in chronic hepatitis C, there is no available treatment for post-exposure phase, but this can be treated with hepatitis B immunoglobulin. Active vaccination, hepatitis C we don't have, but in chronic hepatitis B we have the hepatitis B we have the vaccination. Treatment duration in chronic hepatitis C, it is mostly 12 weeks. In some cases it may be 24 weeks, but current treatment is 12 weeks. In fact, the new drugs which are not yet available in our country at least, the treatment could be just 8 weeks. But in hepatitis B, the treatment is, if we decide to treat, the treatment is usually lifelong. Cure in hepatitis B, cure is a reality. So much so that people after 12 weeks treatment becomes eligible for blood donation, organ donation also, those who respond. In chronic hepatitis B, it is still a dream because cure is defined as a disappearance of surface antigen, and the current treatment does not have that power. But those who are treated with interferon, very few people would accept this option. In them, the chances of complete cure is more, still not 100%, but relatively more. So we still hope for the chronic suppression. Complication in chronic hepatitis C, first CLD and then hepatocellular carcinoma. In chronic hepatitis B, it could be from hepatitis to hepatocellular carcinoma direct, or it could be first CLD and then hepatocellular carcinoma. So these are the differences. That was all about chronic hepatitis B. I just hope that I was able to give you some good account, the understanding of chronic hepatitis B, and some of the details I missed because they were covered in chronic hepatitis C video and acute viral hepatitis. So I think it is best if you watch this video after you have already watched those videos. I really look forward to see you in my next video, which will be on chronic liver disease and hepatocellular carcinoma, because they are common conditions. Thank you very much. This is Professor Aziz-ur-Rehman from Medurstand-Understanding Medicine.